Hi, welcome to the Compliance Connection, the healthcare inspired podcast. I am your host today. And I'm going to welcome my beautiful, beautiful friend, Jennifer McNamara, to the stage. Hello. So today, let's see, today we're going to talk about my favorite subject, which is telehealth. Telehealth. Okay. Can you hear me, Jen? For some reason?
I can hear you. Yes, girl, you're
Oh,
good.
okay. There you are. There you are.
Okay.
I was like, oh no, not again.
I am here. I am here. We are here.
Okay, so today's podcast is about telehealth, right? And many of you have heard me talk about telehealth and all of the things that are kind of going on right now. There's a lot of things that are in the proposed rule for telehealth, but you know, when we think about telehealth and how it is, you think about how it's changed, right? Especially during COVID. Nobody really knew what was happening with telehealth, right? It was like, what's going on? Now it's a medium that is standardized in healthcare. But now we got to realize that there are a lot of, what's the word I'm looking for? A lot of regulations behind it, right? Jen, what do you think?
Well, I'm going to tell you from the very first time that I was involved in telehealth, because most people know I was in like the surgery world most of my career. So when I was at the hospital during the pandemic, I was doing surgeries. I didn't really touch a lot of office stuff, occasionally E&Ms, but our surgeons really didn't do a whole lot of telehealth. Um, at least I didn't touch it because my job was the surgeries. So then I started doing some of that and I was like, oh my, this is crazy. And because it kept changing. And so they would send out these little spreadsheets, what they call payer matrices for us. And they would
Yes.
put on there, okay, this is the GT modifier payer. This is the 95 modifier payer and place of service, whatever. And we had all these instructions. And then like 6 months later, it was changed again.
Oh, yeah.
And it was just constant, right? And then I would have to listen to, of course, people like Terry Fletcher or Christine Hall. They'd be like, hey,
Yes.
this is the new guidance.
Yeah.
And I slowly started to figure it out. And now I feel like we have so much
Yeah.
resources, so many
Yes.
resources. So what I wanted to let everyone know as we go through this is that we do have recommendations for you to get on telehealth.hhs.gov. And before we go any further, what a lot of the information we're going to talk about today is going to come from this site. And so I just want to kind of show you really quick what it looks like. So when you go to this website, you're going to go to telehealth.hhs.gov, and there's so much information for patients, for providers. But I always like to go to the telehealth policy because
Right.
it gives you so much information. You know, what are the Medicare and Medicaid policies, licensure, and we'll talk about that for sure. How do you handle prescribing controlled substances?
Yeah.
What are the changes after the PHE, which we have, of course, surpassed? And then we have this did you know down here about what you need to know about after December 31st of this year. So there's a lot of great things that we can educate people on.
Right.
And so let's talk about it, Maya. Let's talk about telehealth. Let's talk about the history of it, first of all. So, like, tell us the history of telehealth.
Well, I mean, I've been talking about it for a long time, and the first telehealth uh, visit was recorded back in 1966, and it's been around for a long time. And when you think about telehealth, it's really about the non-tangible content that's related to care. So it's non-tangible, but it still is a tool to manage services. So when you think about telehealth and its properties, there are certain things that kind of go along with it. And originally when telehealth came out, it was more so like a luxury. It was only allowed for people who had end-stage renal disease or stroke. And when you submitted these things to Medicare, there were certain modifiers. It was a G0 and it was a G0 modifier that was associated with that. And you had to bill that accordingly. But one of the drawbacks was that it was really a luxury on many levels. Like the hospital had to have a platform, and then the physician also needed to do certain things in order to manage these patients. So then we get we transition into this this venue or this time where COVID was prevalent, and because COVID was prevalent, it was more so an issue about um, uh, making it so that it's not an exposure risk. So you had all of these providers who, really didn't know what was going on. And they didn't even know that a consent was required. It was just that they were trying to provide the service. And so you had a lot of these entities, and then you had all of these rules that were constantly changing. So you had people like me and you who were on top of it for our our organizations, but then you had the smaller organizations who were trying to cope because of the leniencies of HIPAA, and that they were allowing all of these platforms for these services to be allowed. But along with that, there still is some responsibility. Just because they gave you some lenience, you still had to fall within the compliant guidelines in order to bill for those services. I don't know, did you experience that at all with you about the consent and things of that nature with your practice?
Yeah, I mean, we all had to deal with that kind of stuff, and there were so many things I think that people didn't know, and that they were continuing to do. And we talk about compliance all the time, which of course
Right.
this whole season is designed to talk about compliance. And so, like I said, I never really dealt with telehealth um, overall before the pandemic
Yeah.
in my role, but I
Yeah.
know some did. And so
Yeah.
now when the pandemic hits, now we have to figure out, okay, how do we do it compliantly? And so
Yeah.
now we consider, okay, what are the compliant ways to do that? Back in the COVID times, let's fast forward to COVID,
Yeah.
and let's talk now about what we had to deal with, because you had to have a, a platform to do it with,
Right.
but they were kind of lenient, right? They were like,
Yeah.
okay,
Yeah. Yeah. Yeah.
before it was HIPAA has always been in our
Right.
faces, at least for the last 20 years or so. But they weren't like, I guess, as forceful with it. So
Yeah.
people were doing telehealth with so many different things. Like, what were we seeing? What kind of things were we seeing that now would be considered non-HIPAA compliant? What were we doing back then?
Well, and that's what I was, getting at, is that before HIPAA had literally required that you could perform a telehealth visit without the regulatory standardized secured platform. So you could do it via Facebook, you could do it via FaceTime on your phone, you could do it in Google Meets or anything like that. So it was very restrictive in that nature. But then uh as time progressed, and I believe it was like just before the the PHE ended, they said, you know what, we don't want you to do this anymore via non-secured platforms. It has to be a secured platform. You have to do it via a platform that is secured via whether it be online, whether it be face to face, but you had to use these secured platforms that maybe a lot of EMRs didn't provide. So then you had to, a lot of physicians or practices lost all of that telehealth unless you were in a state where you could perform, what's the word I'm looking for? You could perform visits via the telephone. And another site that we probably need to think about is the Centers for Connected Health Policy, where you could find out specifically if your state allowed for asynchronous communication or telephone services that would be allowable, and then that you would be able to use a certain modifier in order to do those services. But at the end of the day, there was a lot of pushback from all of these providers who didn't have the secured platforms, but they still needed to perform telehealth, which required for them to really invest in the venue to see these patients. So, there was a lot of pushback in this regard, but And like you said, going to the Centers for Connected House Policy, telehealth hhs.gov provided a lot of all of these updates. And if you were on top of those updates, there could be possibly paybacks, even though the OIG recently stated when they did a look back of all of those periods that they found that most of the things were compliant. Well, there weren't a lot of rules for you to be compliant. So but at this point in time, there were certain requirements like the consent, and the documentation of the medical necessity. You can't be on the phone for 40 hours thinking that you were going to get a telehealth visit without billing it appropriately. So, there's a lot of things that, came into play. But again, when you're dealing with those types of things, you always have to make sure that there's somebody who knows what they're saying constantly, because it can change. It changed literally every day. Every day. Like 1 minute, one payer was doing this, another payer was doing that. And if you had what's the word I'm looking for? A payer mix where you're dealing with government payers and commercial payers, forget about it. You had to have something in place that you had to check every day to make sure that everything was in place for the type of platform, what was covered, what was not covered. So a lot of them weren't covered telephone visits.
Yeah.
So yeah. So it's just a big, it was a big thing. And it was a lot of stress for these providers who wanted to provide care for the patients, but couldn't.
And I remember something very specific, and I think we've talked about it in general previously, was Incident 2. So
Yeah.
I just got to talk about it because it's always
there's
something that
something out
people
there.
still want to do it. So back in the pandemic, we were dealing with a behavioral health practice that wanted their doctor to be able to see them, but she was literally in another country. Like she was in Canada. And she wanted to be able to see them remotely. And so there were some challenges there because technically, yes, a lot of those rules were waived, the originating site, things like that. So now we are through the PHE.
Right.
We are getting close to some of these, these extensions they gave us for certain coverages, certain things at the end of this year. But how today is it compliant, Maya, for us to practice if we decide to bill Incident 2? What are the stipulations that we have to follow if we decide to do it via telehealth? Like, what do we have to know?
Okay, here we go. Our good friend Terry Fletcher has talked about this too, and I actually talked to her about a couple of things, and I listened to her over at the Orange Irvine chapter when she was given this. But one of the things that is very prevalent is in telehealth, especially when you're dealing with state to state, is licensure. You have to have licensure, right? Even if it's Incident 2, there's something that's introduced where they're allowing, or they want to allow for providers to be provide direct supervision via audio visual. But the gleaning factor here is that you need to be licensed in the state of which you're providing service, right? So when they think about, and let's kind of break this down, right? Let's talk about the originating site and the distant site. The originating site is where the patient is. The distant site is where the physician is, right? If the patient and the physician are in different locations, the physician needs to be licensed in both locations. He cannot be licensed in another country and expect to get a service that's covered. Now, I do know that for behavioral health, there is some exceptions for that. But for the most part, if you're going to provide telehealth services and you are in a different state, you have to be licensed in both states, where the patient is, which is the originating site, and the distant site of where the physician is. And you got to get a consent, and it has to be allowed in the state. Hello.
It just makes sense, right? Because you and I do credentialing. I mean, like, I feel like anymore, that's all I do. But I love credentialing. I know people think I'm weird. It's just, I love credentialing because I love all the pieces. And so I like to touch every piece of the revenue cycle. And so, for instance, when I go through the credentialing process with our providers, I have to look for certain documents. Their
Right.
medical license is one of them.
Yeah.
And sometimes they are licensed in multiple states. So I have a client who is in Mississippi and Louisiana. They have client clinics on both sides. So they have different licenses. And there's going to be different requirements to
Yeah.
get licensed
Yeah.
in a
Yeah.
different state.
Yeah.
So you have to meet those. And
Right.
so if you're going to see a patient who resides in their state, they're not just going to let anyone walk in there, right?
Right. Right.
We've probably heard podcasts about doctors who have tried to practice medicine and really shouldn't be licensed and didn't meet the
Oh.
qualifications. And so we know what happens there. That's illegal. So
Right.
again, it is against the law to practice medicine in a state you're not licensed in.
And I want to add to that too. I mean, it's the United States and everything has borders, right? Everybody has borders. So if you know yourself to have borders from the state and you have people who are seeing people across borders, then it's good practice for you to have state licensure within the borders. And the way um, that it's explained is that there is the the licensure practice where you could have a primary license in the practicing state. And should you decide that you want to expand your practice, you could pay for an additional license, but you still need to be licensed. You can't just expect that because you have licensed in a primary state and you want to practice in a different state that you could just do that. No, no, no. You have to be licensed in every state. I don't care if it's borders or not. If you're in the middle part and you're not close to the border, you may not see people who are, traveling across that border, but you got to be mindful that if you are providing a medical service and it is across state borders and they are in a different state and it's the originating site, you still have to follow those state guidelines that are associated with the telehealth and how and what you are able to do. If it's payment parity, if it's asynchronous, do they allow for asynchronous? Can they bill for telephone services? All of that stuff is contingent upon the state. And if you are not licensed, or if you're not aware of what you can't do, then that's a big deal. I used to work with a lot of people in Indiana, but I live in Illinois, but I'm right on the border, right? And because I'm right on the border, Illinois allows for asynchronous communication where you can communicate and manage people via a store forward policy, right? Store forward communication. Store forward communication is when you're using a mechanism to communicate with patients, whether it be online, telephone, what have you, but it still needs to be secured, right? But in the state of Indiana, they don't allow for store forward, where there's synchronous communication only, meaning that it's a live communication. There is no mechanism that would translate data from the person that you're speaking to for it to be, communicated that way. It's live communication. So if you are in those types of situations and you find that you want to bill for those types of situations, you need to check the state policy, because if you don't,
Right.
you are going to have issues and you're going to be subject to a payback, especially if A, there's no consent, B, they don't allow it for in your state, and then the obvious thing, which is state licensure. If you don't have that and you're trying to do that, you're going to be in big trouble. So have some people like Jen and I, hello,
Hello.
who would be able to assist you with that kind of service, because if you don't, you're going to find yourself in trouble. And then we could, take a look at your claims and say, okay, did you build this with the proper modifier? Do you have a consent on file? And no, it is not the signature that you give when you are practicing, when they first come into the office. No, 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 no. It's a consent for each visit.
Yes.
So,
And document it. We got a question recently, Maya and I, in an education session. And so there's a lot of, things that providers do in between patient care, and they're not physically in front of the patient. And they may want to capture reimbursement for all that work. And it's a lot of work, right? So wanting to capture telehealth visits for texting physicians back and forth or communicating that way. And it's a question we get a lot. We have to remember the E&M services were designed for face-to-face services with the patient. So there are other types of services you can capture talking to physicians, the time you spend there. There is also the element of, hey, say you talk to a physician about a patient and then you don't see the patient for a couple days, but you're going to use that information you gathered from that physician to enhance or add to what you are going to ask the patient and discuss with them. So there's that question of, can I count all of this telehealth, all this time that I spent the day before and the day after? It's crazy. I get that question, and we are forgetting that regardless of telehealth or not, we have to be able to count the time we spent with the patient around that date of service.
Yes.
So remember also with telehealth, you are capturing what you did that day,
Calendar day.
regardless of what you're doing. You may use the information you got the day before from that physician to chat with your patient about what you learned about them. It's getting a history, right? And you're going to verify that. But
Right.
it's that calendar date. That's what you're billing for, is what you did
Yes.
that day.
Yeah.
So if all you did that day was just talk to a physician, you're not going to get to count an E&M service because you don't have enough data to get all the elements in place. You haven't actually
Right.
diagnosed the patient yet. You
Right.
haven't ordered or managed their care in any way at that time. So you don't have enough to capture an E&M level. But you may
Mhm.
have other types of services that you could bill, and we can discuss that, but not an E&M service. So when you ever
Right.
get that question, I don't know if this question's floating around, but we're getting it.
Yeah.
So just be aware. Some physicians, they're so stressed out and they're really trying to get all the revenue they can. They want to take every single thing they do all day and find a way to bill it. And so
Right.
we understand, but
Right.
we want to do it compliantly.
Right.
And we know, guys, next month we are expecting the final rule to drop.
Uh,
It's exciting, right? So Maya, from a telehealth standpoint, what could we be on the lookout for that could potentially be on the horizon for telehealth?
well, and it's really interesting that we talked about that because we initially said, or earlier we said that in the proposed rule, they're allowing for physicians to be present virtually for incident to services, and that also is extended to residents and that type of thing. So the key and the gleaning factor here is that they're allowing for presence, but there has to be evidence that you managed the patient virtually, right? And it needs to be documented for you to get that service. So, and I'm really interested in how they write the definition of general, direct, and personal supervision as it relates to the supervision requirements for the types of services that are allowed. So when you think about those types of things, you have general, direct, and personal. General is when the physician is giving oversight. Direct is when the physician is in the suite, and then personal is when the physician is in the room. So when we think about the direct supervision requirement and them being available via telehealth, there still has to be a consent. There still needs to be documentation that they were present, especially when there's a collaborative relationship, right? So if you have a collaborative relationship, you're providing that type of supervision and you want to get counted for that time, you know, all of that stuff needs to be evidenced in the medical record and proven that you were available and there was documentation to show what you assisted in management with. So the only thing that changes is the manner of which you're providing that supervision, but everything else is the same, right? So you should be very careful and watch. I know people are watching with bated breath when it comes to the proposed rule because people want them to extend this convenience. But you know, when we talk about residents, my stomach hurts when I talk about it. When we talk about residents and the supervision that's related to that, and the physician is being given direct supervision via audio visual, you know, that means audio and visual, and at the time that the resident is seeing the patient, right? Not 2 days later, they read the note and then they give them insight, audio visual. No, it all has to happen on the same calendar date for the physician to get the credit for what the resident has done, and him signing off on the note via the attestation, and that they provided that service. Because if you don't, that could be an issue. So residency is another thing. Incident two services is another. Incident two is about everything that can be done via direct supervision, immunizations, minor services that can be performed. Or when you're dealing with split shared, or we won't talk about that, but when you're dealing with split shared, there's also that element. So when you think about incident two, when you think about split shared, when you think about direct supervision, keep in mind that the only thing that has changed is the manner of which the physician is present. And it has to be audio video. That is the rule currently. And if they pass it for everything else, then and they extend it past the 12/31/2024, you're still going to have to follow those same guidelines. But the only difference is how the physician is present. That's the only thing that changes, is how the physician is present.
Right. You still have to document the same things you would document to capture the code, right? I mean, the code's the code's the code. The description is there. The guidelines are there. So it's really how you carry out the care where you are, but you still have to have the same requirements there as well. So if you have a time-based code, you got to tell us how much time was spent and what you do during that time. You got to talk about it. And then if we're going to bill by time, it's this. If we're going to bill by MDM, it's this. It's the same concept. And yes, in 2025 we are expecting new telemedicine codes, telehealth codes,
and they're supposed to be deleting the telephone codes too.
I know, it's crazy, right? So we're on pins and needles for the new codes as well, to get our new CPT code books like in our hands and like touch them and get the new codes. So it's going to be exciting, guys. So stay tuned for that. As a reminder, I always like to end our show with a reminder of what's coming up next. And so reminder of the Inspired Compliance Seminar that is coming on December 7th. You can scan the QR code if you're here live. It will also be in our show notes for you to register. You don't want to miss that. And guys, I wrote a book this year. I have not been shy about talking about it. Marketing has been everywhere. And we want you to also jump on and grab a copy because, oh, there it is, guys. Maya has her copy in hand. She has it. And guys, we also are giving away this month a free coffee cup, a free coffee mug from Healthcare Inspired for you guys that order a book this month. So jump on there and grab your book. I will sign a copy if you order from our website. So please order your copy today and let me know what you think. We're excited to get more out and excited for the new year for sure. So next week, we're going to talk about more compliance. We're going to dig into the elements over the next several episodes. So next week is element number 1. We're going to talk about our compliance policies. And it's something that you will hear at the compliance seminar from Susan Wahlberg, our keynote speaker. So stay tuned for that. We're going to give you some tips and tricks on, drafting correct policies. We're not going to, of course, go too deep. We don't want to give away some of those gems from the conference, but we do want to give you some education, some tips on effective policies. And so stay tuned for that. And thank you for joining the Healthcare Inspired podcast.